So this week we're going to have a look at one of the problems or challenges that my juniors have been having in the neonatal ICU, which is differentiating between HMD and GBS. So we're just going to look at this clinically. So how to differentiate between the two clinically and how to differentiate between the two radiologically. So please do make sure you stay with me till the end so that you don't miss this. So the case that we'll be basing our discussion on this week is a day 4 late preterm neonate, 35 weeks corrected gestational age, low birth weight of 1.5 kgs, who was born with severe respiratory distress associated with hypoxia. On further history inquiry, this was a child who was not steroid matured and it was an unexplained preterm labor. So based on this, an initial assessment of HMD was made and the patient was admitted in NICU, was started on CPAP and surfactant was given. But there was minimal improvement on the work of breathing and oxygen requirement. A blood gas was done which didn't only show hypoxia but also showed a CO2 retention, so meaning that this patient was in type 2 respiratory failure, and a chest x-ray was done which had similarities to an HMD. So based on this and the fact that this was an unexplained preterm labor, an assessment of congenital pneumonia, possible GBS, was entertained and the patient was ventilated. So this is our case for this week. So the first thing we're going to look at is the clinical differentiation. So let's first look at the onset at which symptoms are presenting, the onset of their respiratory distress. So if you're looking at HMD, an HMD patient will be in respiratory distress immediately after birth, so within minutes after birth. Whereas a GBS pneumonia, it will depend on whether we are dealing with an early onset GBS, which usually presents within the first 24 hours of life, or a late onset GBS, which usually presents after 7 days of life. So that's the difference between the onset at which they present with their respiratory distress. The second thing that is important to look at is the gestational age. If you remember, GBS is common in it's a preterm disease. So the more preterm you are, the more at risk you are of having HMD. If you remember, surfactant is usually produced enough around 34 weeks of gestational age. So any baby who's born less than 34 weeks of gestational age, especially if there's also history that this baby is not steroid matured, so this will be a baby who is going to be more at risk of having HMD. GBS, on the other hand, is a disease of both preterm and term babies, so it can occur in both. What is important to differentiate between the two, other than the gestational age, is also to look at the risk factors. As we have said, prematurity is the major risk factor for HMD. Other things that are risk factors for HMD is like if this is an infant of a diabetic mother. As we know, these kids have hyperinsulinemia, which then counter-regulates the cortisol and therefore production of surfactant. Also, babies that are born with cesarean section are at risk of HMD because they don't go through labor, which is a stress process, and therefore during that stress process there's a release of cortisol which helps in the production of surfactant. So those are some of the risk factors of HMD that you have to look at. Now, looking at the risk factors of GBS, there has to be history of maternal GBS colonization, or if this is a sick mom with fever, or there was prolonged rupture of membranes. So these are some of the history that you're going to take to help you differentiate between the two. Looking at symptoms, if you look at the natural history of HMD, they usually have progressive respiratory distress. We usually say HMD gets worse before it gets better, especially before the era of surfactant administration. So if this is a patient with a mild HMD who hasn't required any surfactant, these babies usually become more distressed around day 3 of life before they actually get better. Whereas a patient with pneumonia will actually with time be getting better every day. And the other thing that is important in the symptoms of a patient with pneumonia, because this is a bacterial infection on top of the respiratory distress, it is important for us to look for other symptoms like symptoms of sepsis, like apneas. Is this child mottled, lethargic? Is he bruised? Is he having petechia? Is he in septic shock? So those are the other signs that they might have on top of the respiratory distress that is important to look out for. systemic features. Just like we've discussed, an HMD patient will not have other systemic symptoms, will just have respiratory distress, which is getting progressive, whereas a patient with GBS pneumonia on top of the respiratory distress will have other signs of an infection, just like we have discussed. So that is how you can differentiate between the two clinically. I hope it makes sense. Now, if we can recap back on our case based on the clinical differences that we have just discussed, and trying to figure out if this is maybe a neonate who could have been assessed as a congenital pneumonia right from the beginning other than HMD. So firstly, this is a 35-weeker. So at this gestational age, HMD is supposed not to be really higher up on the list, because we said at around 34 weeks gestational age, whether the neonate is steroid matured or not, there's supposed to be enough surfactant production. Secondly, this is a neonate who went through labor. It was an unexplained preterm labor. So there was that stress of labor with the release of cortisol, which could have further led in the production of surfactant and decreased the risk of surfactant deficiency, or HMD, in this patient. And therefore, the last thing was the fact that now this patient didn't really respond the way that we would expect an HMD patient to respond after being given surfactant. And therefore, a congenital pneumonia should then be higher up. The other thing that would make congenital pneumonia to be higher up is the fact that this is an unexplained preterm labor. So in neonates, when a mother comes in preterm labor that no one knows why she went in preterm labor, we assume as if it's infection triggered until otherwise. Until we know the other reason, it is assumed as if it's infection until proven otherwise. And therefore, that makes early neonatal sepsis, things like congenital pneumonia, higher up on the list. I hope it makes sense. Now, let's look at the radiological differences between HMD and GBS pneumonia. So the first thing you to look at when you're looking at a chest x-ray is the lung volumes. So a lung volume of an HMD patient will tend to be small because of the surfactant deficiency, which causes atelectasis of the alveoli, and therefore small lung volumes, whereas a lung volume of a pneumonia patient will tend to be normal. So that's the first thing that you look at. Especially, you see this especially before putting an HMD patient on CPAP, because remember, after they have been on CPAP for hours, you may actually miss the small lung volume because the CPAP has recruited some of the alveoli that had collapsed. Then secondly, you look at the chest x-ray findings themselves. So an HMD, they will have this diffuse bilateral symmetrical reticulogranular pattern. This is what will give them the background haziness or the background ground glass appearance that they usually have. Whereas a GBS pneumonia patient, they will also have a diffuse streaky interstitial infiltrates. So these streaky interstitial infiltrates, they also give them a background haziness, which will also look like a ground glass appearance. So that's why sometimes it's difficult to differentiate between these two, because both of them, they can look hazy, but the other one has got normal lung volumes with diffuse streaky interstitial infiltrates, whereas the other one has small lung volumes with bilateral reticulogranular pattern. Both of them can have air bronchograms. So grade 2 HMD will have air bronchograms, whereas a pneumonia tends to have air bronchograms. Also, with the pneumonia, you might have elements of pleural effusions in the chest x-ray because of the inflammatory process that is going on because of the infection. Whereas in a chest x-ray of an HMD, you will not see no pleural effusions. So that's how you differentiate between these two conditions radiologically. So what usually makes them look the same also is the fact that sometimes the two diseases can actually overlap. They can actually coexist in one patient. You have a patient with an HMD with a superimposed GBS pneumonia, then the x-ray will actually look the same. or a patient with GBS pneumonia. There's a theory that patients with pneumonia, the inflammatory process, the cytokines, can actually inactivate the surfactant production and therefore give a picture of a picture that is looking like an HMD because the pneumonia has inactivated the surfactant. So those are the two theories that have been postulated as to why do the two conditions tend to look the same. I hope it makes sense and it's clear.